Hello, welcome everyone, and thanks for observing the 2-minute silence with us. This is a webinar of the Global Observatory of Long-Term Care, and you're all very welcome. And just so you know what the observatory is, it's a platform for cross-national learning to help us improve and strengthen long-term care systems all over the world. And we're looking at shared challenges and looking at how countries are addressing them. And we're also looking at research that can help us do better in terms of long-term care. And the observatory is basically run through interest groups that share work on their topic of interest. Today, this is a webinar of the Pain in Long-Term Care interest groups, but we also publish blogs, and we are very happy to share your work. So please get in touch. My colleague Naz is sharing some links to help you find out more about the observatory. I'd like to say that you're all very welcome as well to join us on the 28th of November when we're holding a full-day event called Changing the Narrative on Long-Term Care, where we're going to be looking at some of the negative myths that we have about care, and we're going to see how we can use evidence to have better narratives on the value of care and the case for investing in care. The next webinars we have are in the screen now. We have quite a good list, stretching already into March. And tomorrow we have one in Spanish on care in the community, and then we've got some on quality management, innovations. And we're going to be talking again about pain in long-term care on the 5th of March. And some of you may also be interested on the webinar on the 2nd of February. We haven't got the full details yet, but we'll share them soon. That is looking at sustainable continence care in long-term care. And that's all from me. I'm very happy to hand over to Manuela Hödel from the Pain in Long-Term Care Interest Group, who's going to lead and run today's webinar. All yours.
Thank you very much, Adelina. Hello and welcome, everyone. My name is Manuela Hödel. I'm from the Medical University of Graz, and together with a colleague, it's Sandra Zwakalen from Maastricht University, I am leading the special interest group in pain in care homes. We created the group, I think, 2 years ago. Sandra Zwakalen is a researcher since the, I think, last 20 years in pain in care homes on the one hand. And the other hand, why I joined as a leader this group is that I have a big project on pain in care homes, and that's why we created the group. If you want to join us, please feel free to also register to our steering group. The next time we will hold a shared meeting together, as Adelina already said, on the 5th of March. Yeah, I want to go directly into the topic of today, and just give me a second to share my slides. So now you should see it. I'm very excited today. About more than 90 people are registered for this webinar. And I think that it's about the topic, and it's about the practicality or the practical toolkit with non-pharmacological interventions for pain management in nursing homes. And I want to go with you through the agenda for today. I want to give you a short insight into the whole project. So who is involved? Then I want to tell you why we developed the toolkit. Just a short slide about how we did it. I do not want to go into the methods in detail today. If you want to know more, just write me an email, and then I want to show you the toolkit on itself with the content and so on. So focusing on the project behind the toolkit, I've told you I have a big project. It's a 5-year funded project with about nearly 600,000 euros. It's called the Opinion Lab. So it's in cooperation with one long-term care organization. It's the Caritas. And in this 5-year project, we are working with the Caritas. What you should know and keep in mind that the Caritas is an organization, a non-profit organization from the Catholic Church. It's divided into 9 regions, and the Caritas has 16 nursing homes in Styria. But we are only working, and you see it here right now, we are working with one nursing home. It's in St. Peter in Graz. Graz is the main town of the federal state of Styria. And how do we work there? Really practical. In this nursing home, we have 3 wards, about 120 residents. We have, of course, management persons, and we have about 40 to 50 persons that are working in nursing care. And one of it, and you see the guy on the right side on the slide, he is Wolfgang. Wolfgang is a nursing aide, so he's not a registered nurse. And on the left side, you see myself and Eva. And we 2 scientists are working every Wednesday with Wolfgang, who is called Nursing Home Linking Pin, together for 8 hours. So each Wednesday, we are visiting the nursing home. We are working with him on scientific research, on methods. We are doing a lot of things. And I also wanted to show you how Wolfgang is supporting us, because you can imagine Wolfgang is a nursing aide, and he has not the training or the competences to doing nursing research by himself. So what he is doing, he is helping us with literature search. He is not really writing the ethical proposal. This is not really correct here. He is reviewing it. But for example, he is helping us with developing questionnaires, guidelines for interviews. I can give you here a short example. We developed, or not we developed, there was already a questionnaire available, and this questionnaire consisted of 4 questions. And then we asked Wolfgang if this is fine and okay, and he said, yeah, that's nice. And then we are going to prepare the translation, and within the translation process, we did a cognitive debriefing. And out of these, the questionnaire existed out of 4 questions, but the cognitive debriefing was like 30 questions. And he told us, what are you doing? So sometimes he is just showing us that the scientific world and the real practice is not really matching. So we have to go on a little bit more pragmatic. He's helping us again and go on with collecting data and things like that. So this is the project behind the toolkit. There are also other peoples involved. For example, it's Daniela Schoberer. She should do that presentation today, but she's not available. She is currently at the GCA conference in Boston. She is the brain behind the toolkit. So if there are really specific questions on the methodology, just write me and I will forward it to her. The first question I want to answer is why we developed the toolkit. And as I told you, this is a big project. And in the first year, we did study 1, and it was about pain and quality of life. A total of 67 residents participated. And of these 67 residents, 28 residents had pain. This was interesting because we were thinking about a much higher prevalence, but okay. We also had a look at what did the nurses, the nursing staff, the care aides do in order to manage pain. In total, 154 pain relief interventions were set, 67 persons. So you see 1 person is getting more than 1 pain relief interventions. But what you also see, and I've highlighted it here with the pink frames, a lot of them were medications, pills. And we were thinking, okay, that's interesting because there are other interventions like, I don't know, cold heat therapy, occupational therapy, and so on. So what we were thinking about, what is happening here? On the other hand, we also asked the residents, what about pain management? And what they told us, and here are the 2 orange colored blocks important, they told us that the nursing staff mostly used medication, but they also told us that they loved and they mostly used for themselves non-pharmacological interventions. I want to give you two really nice examples. There was one guy who told us that if he has back pain, lower back pain, he is sitting close to the heater in his room because the warmth is helping him to relieve pain. And the other thing was a lady, and she is doing gymnastics her whole life. And she told us when she is, for example, has problems with knees, hips, and that, she is trying to do her normal gym things that she's done her whole life in bed. Of course, not so in an extensive way, in an other hard way, but she is doing that. So we were thinking, okay, there are a lot of non-pharmacological interventions, but on the other side, the residents are doing these non-pharmacological interventions on their own, and they want to do that. So we were thinking about what is happening here. And then we had our annual meeting, and within the project, in this annual meeting, the scientists are meeting together with the management of the Caritas, so of all of the nursing homes. We are meeting with the nursing director from this one nursing home, with the nursing home staff, with a few persons, about 10 nursing home staff and care aides are included, but also residents. And what they told us was, yeah, we know that there's a cold therapy or a heat therapy or occupational therapy, that it helps, but we are not sure when is it really effective. So what is the disease behind? When is a warm therapy or application effective for which diseases? And this is why we developed a toolbox with non-pharmacological interventions for pain management. How we developed it, and this is only one slide, we used 3 steps, let me say it like that. The first step, we searched for the scientific evidence. There we used already available websites, German websites, like Cochrane or Wissen was wirkt, things like that. And we searched for the non-pharmacological interventions. Maybe I'll start a step further. What we did, we've asked the staff, the residents, we've asked national and international experts to give us a list of non-pharmacological interventions, and the list were about 50 interventions. And then we've ranked that interventions, the nursing home staff did that, and we started to search for the scientific evidence for the first 20 interventions, because we could not do like 50, 60, 70 interventions, so we started with 20. And then we are going to this website. They were already available, and we had a look. For example, is there already scientific evidence for physical exercise or for cold therapy, heat application, and so on? We found 4 interventions where we found no evidence on these 10 different scientific, on these websites. For example, the one was aromatherapy or aroma care, and so with essential oils. And the other one, for example, was empathic communication or empathic attentions. And for those, we did rapid reviews. So after we had all of the evidence from the website, from the reviews, we were going with all of the information into workshops. So we asked the staff, and on the other hand, we also asked the residents after it. We asked them, what do you think about the feasibility of the invention? What resources do you need? Do you think that the resident itself or her family can be involved in this? And we graded, or we ranked and sorted the interventions in terms of acceptability, feasibility, resources for the nursing home. And we also asked the residents the same questions, but these were not workshops. We did it together in personal communication, so one-to-one, face-to-face. At the end, we had our toolkit. And I think this is the most important thing for you right now. I have here, this is the toolkit. I have here a QR code, and the whole session is recorded. So afterwards, you can have a look at it really intensively, and down there is the link for the whole toolkit. I want to show you what is in the toolkit. There is one general part, and it's about the introduction. In the introduction, there are things like, please do an assessment, who is allowed to do what. Please be aware that this can, of course, differ between the countries. What are the most important aspects, and so on. And then we have three big parts. Is the indications and recommended interventions, indications and interventions with unclear evidence, and the indications with non-recommended. As I told you in the introduction, key information on pain management, but we also included, for example, why rest or bed rest is not beneficial, and why non-recommended intervention may also be implemented in certain cases. Think about a person, a female, male nursing home resident who is doing a cold application for her whole or his life since, I don't know. And then you told the person she or he shouldn't do that anymore. So always be aware when you use the toolkit, the most important things are the preferences of the residents. He or she is in the center of each intervention that should be selected. And here I have one example. Sorry, I tried to move that a little bit. I'm not sure if you can see everything. Here is a list of indications and recommended measures. And as I've told you before, in the annual meeting, the nursing home staff told us that they do not know, for example, if physical therapy is effective in acute pain or acute lower pain and things like that. So they were insecure, and this was the reason why they didn't do it. So in the introduction, in the general part, you have a whole list of indications, and on the one hand, which interventions are recommended, which interventions cannot be recommended because currently there is unclear evidence. Unclear evidence means that there are too less studies, or the studies are not done in a more or less perfect way. And there is also a list of indication and non-recommended measures. As you can see here, for example, for people with breast cancer, lymphatic drainage with essential oil is non-recommended. Now let's come to the big parts. We do not only have this introduction with the indications and recommended, or the interventions recommended, or unclear evidence or non-recommended. We have three big parts, and I gave you here some examples. For example, it is recommended to do empathic attention and communication. And what you see here, I think what is really interesting for those who are working in nursing home practice, or even for manager to link it to other people, these are the tips and tricks. So every measure, every intervention has a list of measures, the indication, contraindication or adverse effects, and also tips of tricks. So these are the things that I think are really, really important. And for each of these interventions, of the included interventions, it's always the same format, format built. For example, another one, physical exercise is recommended. And here we included a table because it was too big. Here on the left side, you see that for osteoarthritis, the promotion of physical activity or low intensive endurance training is recommended. So again, we also here on the top, you see some tips and tricks how to do that. We also tried to adapt these tips and tricks to the physical ability of the nursing home residents together with the nursing home staff. Then I have one intervention. It's relaxing therapies where the evidence is unclear. You see here biofeedback, progressive muscle relaxation, autogenic training is not clear if it works in fibromyalgia. Or another one we have here, the mattresses. We have special mattresses for rheumatic pain. And again, these are measures or intervention with clear evidence. Nevertheless, please be aware if the resident wants it and is doing it for his or her whole life, please think about giving him or her the opportunity to use these interventions for pain relief. And yeah, I've already mentioned it. We had a few of them that are not recommended, and one of them is the lymphatic drainage with essential oils. Yes. I want to come back to the whole project. I think within the project, through that regular exchange, the work together, we also decide together, we can really respond fast. And within the annual meeting, even though it takes a full year to develop the toolkit, I think we really developed something that is important for nursing home practice. And this is the one thing that we want to establish. We do not want to establish research just because of research. We want to establish research because it is useful and applicable for the nursing home practice. And the applicability can be seen because we know the nursing homes now for 3 years. We know the residents, we know the staff. We know what are the important things for practice, and therefore we can work on the important things for practice within that 8-hour every Wednesday. So this is the whole team in one of the annual meetings, and on the left in the first row, here you see, for example, one of the residents is Krista, and she is always with us. So thank you.
Thank you so much, Manuela. And I can see people have appreciated your talk. And we can open for questions and comments if anyone would like to raise their hand.
Maybe one thing that might be interesting or important for you, the toolkit is open access, freely, fully available as long as you cite us as the authors, and it's available in English. The web page is not available right now in English. We're working on that.
Actually, if you want to share a link with us, we can also put a link on the interest group so people can access it from there as well. Yeah,
that's a good idea.
Have we got any questions for Manuela? And happy to also hear about your comments of, because I think many of you are actually working in the sector and in care homes. So please feel free to also share your experiences and impressions of how this might work for you. So I see Pat has her hand up.
Hi, Manuela. Thanks ever so much. That was really interesting. On your list of drugs, you talked about non-opioids other. Can you just clarify what you mean by that?
We didn't check that, or let me say it like that. We had the names, but we clustered it. So I'm not sure exactly which ingredients are meant right now. I have to have a look in the data. So if you give me 1 or 2 days, then I can give you a really detailed feedback.
Brilliant. Thanks very much.
Yeah, I just put into the chat the link for the toolkit.
Thank you, Manuela. Any other comments or thoughts? So I see that that it's being appreciated and in the chat. And we're very keen to also hear about other projects or practice experiences that you may want to share.
Maybe just one more comment, because we know the nursing homes, so yeah, since 3 years, and we are very familiar with it. When you use that toolkit, there are the tips and the tricks and things like that. But what we also recognized is that sometimes they need more information. So for example, how are you doing the long endurance training, so the physical exercise? So what we have done, or not we, the nursing home developed a working group, and they developed templates, let me say templates. So they described step by step how to do, I don't know, a cold application, a warm application, a physical exercise, and things like that. We did not do that because it's about the applicability in the nursing home. They know which resources they have, which materials. They know how to do it more or less. The registered nurses were establishing these templates, and with these templates, there is a really, I think, a good foundation for people who have never heard, for example, about, I don't know, a specific physical exercise, how to do that with the nursing home residents. So I believe if you do it in a long-term care organization, go with your staff through it and think about it. If you need more information on, I don't know, cold application and so on.
Thank you. We have a question from Heather Tonner. Would you like to unmute, or if not, we can read it for you?
This is interesting because we had the first big discussion we had is, or the nursing home staff told us, we are not allowed to do the cold application and the heat application and the physical exercise and what on. And what we did in the forefront is we've asked a lawyer from the nursing home organization what is allowed and what is not allowed. But he is really, he is into that topic, and he is employed at the organizational level. So the first thing was, he told us, yeah, you're allowed to do that. This is the first thing. And the other one is that it should not be done the way that you put all the medications away. But before improving a dose, increasing the dose, try it. So it should be like, how is it called? Additionally, yeah. And if it works, you can reduce the doses. So, and that's why we do not have any pushbacks, because it's the nursing staff competences, and they are now doing it within their working fields. It doesn't matter. It doesn't mean that we are, fighting with the doctors about medications or pills, even though this is right now just a big topic in Austria in general.
Thank you. And I see the feedback that's good to hear. And Pat, I see your hand.
Oh, yeah. Sorry, another one from me. Manuela, are you planning to roll it out on a larger scale to different nursing homes? And if so, would you be interested in evaluating it in the UK?
Feel free, do whatever you want to do. So the first thing is we are right now implementing it in the one nursing home. The second thing is, we want to roll it out, but first in the Caritas, in the 16 nursing homes. So I'm interested, but please give me or call me in 10 years. I think it's just, because implementation is also a thing you have to focus on. It's not about give it to them, but really to think about with the organization, the management team in the nursing home, each nursing home, because they are so different, how to implement it. So just feel free, if you want to use it, if you want to implement it, just go for it, okay? Because right now I do not have the time resources.
Thank you. Any other comments or or feedback or sharing of your experiences in pain management? And also very interesting to hear also about this, the fact that you went to a lawyer to make sure that there were no issues. It sounds like a very cautious approach and very, very careful. Thank you. I see Tracy Sutherland, you have your hand up.
Yeah, it was more a comment, because I know up here in Scotland there would be almost pushback from the nurses in the care homes, worried that if they tried the non-medical interventions bit, and if it didn't work, would they be getting sued by the relatives of things? Because I know I try, and part of my role is to try and get people to use non-medical interventions, but there is always this fear, but what if we try it and it's delayed the treatment to the GPs, and then the GPs will sort of have a go at them, and then the care inspectorate and things like that.
I totally understand that remark or that question. I wouldn't say we had the discussion, but we had it in mind, especially when thinking about the relatives and the families. Yeah. But this is one point, what we do right now in the implementation. We are not choosing the intervention just for fun. We are choosing, first of all, we ask all residents, what are your preferences? What have you done in your life when you have, I don't know, shoulder pain, knee pain, whatever, head pain, yeah? So these are interventions that they're already done for their whole life. So this is also how you can argue, they document it, and then you can argue when the official, I don't know, how do you call them? When the family is coming, because on the one hand, when the family is coming, because they've already done that. This is the first thing. And also when the legal directory who is proving the nursing home, you can also tell them they've already done it. We've tried it. It's not working. Of course, you have to evaluate. I mean, it's clear. You know the person has pain. Then you set the intervention, and then you measure again. Which scale doesn't matter, yeah? So, but I think the point is, if you want to implement it, think about what are the preferences of the residents and go on with, or start with them, because then it's much easier to work with the family and the relatives. And on the other hand, to those who are checking the nursing homes with legal rules and things like that. Yeah.
Thank you. I'll quickly mention the comment on the chat and I'll go to the next hands. So there's a comment from Debbie Bevington, and she says that the CQC and NICE guidelines might help with staff reluctance. Now, for those of you not from the UK, the CQC is the body that inspects and regulates the quality of care. So, of course, that would be an endorsement of the approach. And the NICE is an institute that of clinical excellence that looks at the evidence and then makes recommendations based on evidence. And of course, that is also seen as a very strong endorsement. And then that's something that definitely the medical profession would recognize as a source of authoritarian authority. I'll go to Fiona first and then Holly. So Fiona, if you want to unmute.
Thank you. Manuela, that was really helpful. Thank you. We're really excited to see this toolkit. It's been an issue we have been battling for the past decade in services trying to support care homes to better recognise and manage pain. My question was around whether the participants in the study were able to self-report their pain, or were there kind of observational measures used? Because often the people we're supporting have a diagnosis of dementia. They're often quite advanced with quite complex needs, and they may no longer be able to recognise effectively or communicate effectively that they are in pain. And our struggle often is about getting staff to recognise other signs that someone might be in pain and then take necessary steps.
So for the first study, we used a numeric rating scale, even though it's for hospitals, but it was already in the documentation system of the nursing homes. And this was for person who can self-report. And on the other hand, we had the PAIC, and this was done by either we as a researcher, when we were familiar with the resident or with a nursing home staff member that was familiar with the resident. So what this was done in the first study. So we also had the proxy instruments, of course. Now in the implementation phase, what is interesting, we use again the NRS and the BESD, and I have no idea how it's called in English. It's a German version. They already should work with it, but they didn't do it. So yeah, this is again an implementation thing. The document or the assessment instruments for persons who can self-report are there, who are not able to self-report, but they are not using it. So this is one part of the implementation, and that's why I said implementation. It's such a, you really have to have a look. What are their needs? And if you see that they are not using it, then you have to really go on to that, to go to training and things like that, or even use another scale if there is one available.
It's not that they don't have the scales. We use the Abbey Pain scale, kind of observational tool, typically in the across the care homes that we support. We're a mental health NHS trust supporting those care homes, but it's more that they just don't recognise that if they can't, they might say, well, we've offered them PRN medication, but they declined it. But then 5 minutes later, there's an incident because of something. We're like, well, it's linked to pain because that person has a leg ulcer and an infection in their bone or whatever it is. So it's just that bit that they're struggling to kind of identify that something might be linked to pain or discomfort.
But this is interesting. I'm not talking about the registered nursing. Who is recognizing the pain are the people that are working directly in care, and these are the care aides. And the care aides know the nursing home residents. So even though the registered nurses have to do the assessment, I think the point is where you can recognize there might be some pain are the care aides. So this might be maybe a communication thing, because the care aides know there might be pain, but then they have to communicate to the registered nurses to do the assessment. And these are all implementation things, and we are right now within the whole implementation process.
Crazy. Thank you. It's really helpful, though. Thank you. Hopefully this will really help kind of raise the awareness, if nothing else, that things need to be thought about. So.
Yeah, absolutely. Thank you.
Holly, do you want to ask your question?
Hi, thank you for your talk. That was incredible. And yeah, just looking through the toolkit now. My question was very similar to Fiona's, actually, hence why I put my hand down. I was just wondering about working with individuals who have dementia, and if there's any specific recommendations that you have within each of the PIN management. But yeah, my question was answered. Thank you.
We are not recommending any specific scale. We are right now using this one who is in the nursing home. They are familiar with it, and that's it. It was never the focus to go into the assessment and things like that. It was the focus to go into the management and into this non-medication or non-pharmacological interventions. Yeah.
And I think you discussed some of these in previous webinars, Manuela. So I've put the link to the video recordings in case anyone wants, if you have a moment, they're all on YouTube, you can catch them there as well. Do we have any other questions or thoughts? If you raise your hands, I'll help you unmute. Right. If not, I think we can thank Manuela for an excellent presentation. And just to like to say again that we're delighted that so many of you that I think are new to the observatory have joined us today. I hope you find these types of webinars helpful, and we're very happy to also hear about your proposals on topics to cover, on things you'll be interested in the future. And I see one more comment. Let me just check. Oh yeah, thank you. Very informative. So yeah, I think we can thank Manuela, and thanks for sharing the toolkit, also for sharing your address in case anyone has any questions. And we look forward to seeing you at future webinars. Thank you very much.
Thank you. Bye.